Dear colleagues, today I'm going to present my progress report on preconceptional, gestational, and postpartum carbohydrate metabolic disorders. My name is Dorina Greff. I'm a resident doctor at the Department of Obstetrics and Gynecology. My supervisors are Szabolcs Várbíró and Eszter Horváth. My vision to increase fertility and complication-free pregnancy rate, and my mission to achieve my vision by novel prevention strategies and to improve carbohydrate metabolism. Please let me introduce my 3 ongoing projects about new therapeutic possibilities in polycystic ovary syndrome and gestational diabetes mellitus. In the first meta-analysis, I'm going to investigate the safety and efficacy of metformin and inositol treatment in polycystic ovary syndrome. Polycystic ovary syndrome is one of the leading causes of infertility. It affects about 5 to 20% of women, and the main characteristics of this disorder are polycystic ovaries on ultrasound examination, hyperandrogenism, and menstrual irregularities. Up to 60% of women with PCOS are also overweight. The pathogenesis of this disorder is still unknown. However, insulin resistance was shown to have a crucial role in its pathogenesis. Insulin resistance presents in 75% of lean and 95% of overweight women with PCOS. Metformin is commonly utilized to reduce insulin resistance. However, it has some gastrointestinal side effects, such as bloating, nausea, diarrhea. That's why another medical option is needed, which can be inositol. It has no side effect, and according to an Australian guideline, inositol can currently be considered as a complementary therapy in PCOS, with emerging evidence on efficacy highlighting the need for further research. That's why our aim to examine the potential beneficial effect of inositols in the treatment of PCOS. Are inositols efficient and safe in the treatment of PCOS? This is our clinical question. The population would be women with PCOS. Intervention is inositol. Comparators are placebo or metformin, and our primary outcomes are presence of ovulation and cycle lengths. The secondary outcomes are BMI, pregnancy rate, carbohydrate metabolism, clinical and laboratory hyperandrogenism, and side effects. Our hypothesis is that inositols are non-inferior compared to metformin regarding the presence of ovulation and cycle lengths. We did the systematic search at the 20th of October, and we finished at the end of the full text selection, we found 22 eligible articles. Please let me now turn to the results. Our primary outcome is cycle normalization. To have a regular menstrual cycle is the key to women's fertility. We found 2 eligible articles comparing inositol treatment to placebo, which shows us that in the inositol group, twice more likely to have a regular menstrual cycle compared to placebo. We found also 3 articles comparing inositol treatment to metformin, which shows us that there's no significant difference between the two groups, suggesting that inositol is non-inferior compared to metformin. One of our secondary outcomes is BMI. As I mentioned earlier, up to 60% of women with PCOS are also overweight. We found 9 articles comparing inositol treatment to placebo, out of which myoinositol seems to have potential beneficial effect on reducing BMI. We also compared myoinositol treatment to metformin in this outcome, where we found non-inferiority between the 2 groups. Obesity is not just important because of hyperinsulinemia, but hyperinsulinemia also causes higher level of testosterone and lower level of sexual hormone binding globulin, which results higher level of free testosterone, worsening the symptoms of hyperandrogenism. That's why the next outcome I would like to present is free testosterone. Here we found articles only comparing inositol treatment to placebo, which shows us that inositol is significantly better in reducing free testosterone compared to placebo. With this table, I would like to summarize the results what we have in hands right now. And comparing inositol treatment to placebo, we found inositol significantly better in case of cycle normalization, BMI, and free testosterone. And comparing inositol treatment to the conventional therapy, we found non-inferiority in the cases you can see on the table. The strength of our study is that we not just compared inositol treatment to placebo, but also to metformin. We investigated plenty of outcomes, and we also investigated the different inositol stereoisomers too. The limitations are the small number of RCTs with small sample size and the too heterogeneous population. What should we implicate for the practice? Inositols might be considered as a non-inferior treatment compared to metformin in PCOS, and we should take into consideration to complete metformin therapy with inositols. Implication for research would be further RCTs are needed with bigger sample size, and the additive effect of metformin and inositol co-treatment should be examined. We conclude that inositol treatment has beneficial effect on several parameters of PCOS, and in the most relevant outcome measures show that inositol is non-inferior to the gold standard treatment metformin. These data suggest that inositols are promising alternative treatment compared to metformin, especially on those cases who had serious gastrointestinal side effects from metformin. In the second meta-analysis, we are going to investigate the safety and efficacy of inositols in the prevention of gestational diabetes mellitus. Gestational diabetes mellitus is the most common disorder related to pregnancy. It affects 7% of pregnancies globally, and it can cause several maternal and fetal complications such as macrosomia, jaundice, neonatal hypoglycemia, and in long term, it increases the risk for later development of type 2 diabetes mellitus and cardiovascular events. Despite of these facts, there's no medical treatment is generally prescribed for the prevention of GDM. But inositols are shown to increase insulin sensitivity. That's why our aim to investigate the preventive effect of inositols in gestational diabetes mellitus. Can inositol treatment prevent the development of GDM in pregnant women? This is our clinical question. Population is pregnant women. Inositol are our intervention, and comparators are no intervention at all or placebo. And our primary outcome is the GDM diagnosis by the time of oral glucose tolerance test. The secondary outcomes are need for insulin treatment, OGTT, maternal and fetal complication listed below. Our hypothesis is that inositols can decrease the incidence of GDM compared to placebo or no intervention at all. And the clinical implication would be to improve dietary supplements for pregnancy. We did a systematic search at the 5th of November, and at the end of the full text selection, we found 11 eligible articles, and we have finished also the data extraction and risk of bias assessment. So now we are waiting for the statisticians. Based on our second meta-analysis, we started to prepare a protocol of a randomized trial with the title of Inositols in the Prevention of Gestational Diabetes Mellitus. The background and clinical question and PICA are perfectly the same as I mentioned in the second meta-analysis, and our clinical implication would be to improve dietary supplement recommendation in early pregnancy to reduce GDM incidence. Our goal is to submit our 2 meta-analyses by the end of May, and hopefully we can start the patients enrollment by the end of June too. I would like to finish my presentation with a quote from Eleanor Roosevelt: "The future belongs to those who believe in the beauty of their dreams." Thank you for your attention.
I have 2 questions. One is similar to the previous one, that in the middle box, I mean, when you compare inositol and metformin, actually, in one study, it seems to be significantly better. In the other study, is significantly worse, or I mean, so increasing or decreasing. So, what is did you look behind the data? That what is the cause for this kind of heterogeneity?
As I mentioned, as a limitation of this meta-analysis, the cause behind this question is the too heterogeneous population. For example, in this box, triacecaram included patients who undergone IVF cycles. So it means they received additional hormonal therapy. So probably that's why they would in favor control. And actually, this is one of our biggest outlier.
Yeah. I mean, this is very important. I mean, this is one of the great thing about meta-analysis, that you can actually find out what is the difference, and then maybe actually you can build it in your own clinical study. That's right.
Yes.
Well, my other question is that I'm really not familiar on this field. So you said that so you use inositol because metformin have side effects in some of the patients. I really don't know, so I'm just curious that what is the percentage of serious side effects? This is thing one. Thing two, is there any side effect of inositol-like compounds?
According to the literature, inositol doesn't have any side effect, but to discuss it with some dietitian, they said that patients sometimes complain about side effects also, but not as serious as in metformin therapy. And the percentage is about 20% based on RCTs what we included into this meta-analysis.